Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery Tips. So today I welcome to another lecture in the series Radiology. Today we will be discussing the radiography pathology of pleural space, which is coming under the radiography pathology of thorax. Under thorax we have covered the larynx, the trachea, the esophagus, the diaphragm and the mediastinum. This is pleural. Another two are remaining, that is the cardiovascular system and the lungs. Okay, so we will cover subsequently. If you have not watched those videos, do watch them because some portions are interlinked between them. Entire thoracic are interlinked. Okay, so some concept I may skip because I have explained in previous videos. Okay, so today we will be discussing pleural space. I will give the link in the description so that you can watch. So this first is anatomy. As you know, if you will take a coronal plane section, then this is the figure. The outer one is the thoracic wall. This is the thoracic wall. The thoracic wall has been lined by pleura. Pleura is a double membrane structure. It has a parietal layer and a visceral layer. Here what has been drawn is parietal layer. This is the parietal layer. Parietal layer has been named according to its position. This particular portion, this one is the costal pleura, which attaches to diaphragm, which is diaphragmatic pleura. Then this is the mediastinal pleura. Okay, here the lungs has been drawn. The visceral pleura lines the lungs. Let me use a different color so that I can appreciate. So now this is lungs, which is lined by the blue color is the visceral pleura. Okay, so this is left side, this is right side radiographically. So this particular pleura is the visceral pleura. Visceral pleura. Now the lungs has fissures which divides the lungs into different lobes. In left side you know that there is one fissure which divides into the cranial and the caudal lobe. Okay, the cranial lobe is also has a small fissure which divides into craniocranial, craniocaudal lobe. Okay, so all these fissures are also lined by pleura. So when you will be discussing the pleural effusion radiographically, the most noticing factor is these fissures. Okay, one of the radiographic sign is finding these fissures. Normally these fissures are not visible radiographically. If at all visible without all other signs, there are some 5 to 6 signs of pleural effusion. If you are not finding all of them, only you are finding this fissure, it may not be clinically significant. So you should know that these fissures are actually visible in radiographically in some patients. Okay, normally they are not visible. Let us take this dotted line is the heart. Okay, let me take another section, basically the transverse plane or cross sectional view. You can see here all the layers has been drawn. The outer one is the thoracic wall, next is the parietal layer, next is the visceral layer. The dotted line is lungs. Lungs has been lined by visceral layer. Okay, this is basically anatomy. This is heart, and the middle is the mediastinum, where heart lies is in the mediastinum. Okay, so this is basically the structure. Just take a look. It is similar to the coronal plane, only a different view. Next, fissures. I told you about fissures. Okay, so from different view we will find different fissures. They are nearly same, but this is left lung, this is right lung. If you will take a right lateral view, then you are mostly evaluating the left lung. If you are taking a left lateral view, then you are mostly evaluating the right lung. I have discussed in interpretation of thorax that the dependent side lungs usually becomes atelectic, or the volume of that particular lung is decreased. So due to that, the radio opacity of that particular lung increases and you cannot evaluate. So basically you are evaluating the contralateral lung or the non-dependent lung. So these are nothing new. You know that the fissures. Okay, here these fissures. One thing you have to remember that the ventral fissures here and here, they lie just at the level of heart. So when heart is of soft tissue opacity, the many times you may not appreciate these fissures, while this fissure you can appreciate. Okay, this fissure you can appreciate. We will see some radiographical. Just know that how they look. Now DV and VD. DB and VD. You can see here. You can see the fissures. This is accessory long lobe. Okay. CS is basically costosternal recess. Okay, or sulci. It is just extension. And these are basically fissures. Okay, fissures. Now here is F dash actually. This F dash is not fissure. This F dash is actually, can you tell, this is a reflection. This is caudoventral reflection of the mediastinum. I have discussed mediastinum. Already I have discussed. This M is mediastinum. Can you name this deflection? This is cranioventral reflection. This is caudoventral reflection. Here is the cranioventral reflection, because the ventral mediastinum is not exactly straight, it is slightly deflected. So these are basically fissures which you can see. Okay, let us see some radiographs so that you can identify. So first I told you that fissures may be visible and it may get confused with the ribs. Okay, so you have to identify between the what is the fissure, which one is the fissure line, which one is the rib. So basically the fissure lines are usually curving. Okay, you see this is a fissure line. You can see it is more curving. The concave side, this concave side, the caudal one will have a concave side. Okay, but if you see a rib, or especially not rib, especially it is basically chondrocostal cartilage, or you can simply costal cartilage. They usually get confused. You can see here a cartilage. Cartilage are usually thicker. They are more prominent, and almost every time if you will track this, it will attach to a rib. Okay, but this may not attach, and they are comparatively more straight or linear. Okay, but these fissures will be curved. Like here you see this one. This one is a fissure. Okay, which divides lungs into different lobes, while you see this one is a cartilage, costal cartilage. So this cartilage is usually, you can see it's thicker, and if you will track it down, then it attaches to a rib. Okay, so this is basic difference between the fissure and a rib, which you may get confused while evaluating the radiograph for pleural effusion. Okay, the most common disease of pleura is pleural effusion, and the second one is the pneumothorax. So the pleural fluid can be of three types. It can be exudate, it can be of transudate, or it can be modified transudate. Okay, radiographically you cannot identify between three, only you can identify the fluid. Okay, so for evaluation you have to do thoracocentesis, then after lab evaluation you can tell that whether it is a exudate or transudate or modified transudate. One more thing, pleural fluid usually they are evenly distributed between two sacs, especially in dogs and cat, because the mediastinum contain some fenestration, they are not complete. But there will be certain conditions, especially when the fluid is very thick, like pus. We'll see radiographs also like pus, especially in case of pyothorax. The fluid distribution is asymmetrical. Okay, the fluid distribution becomes asymmetrical. When you will find asymmetrical distribution of fluid, then you can tell that the fluid is kind of thick and it might be pus. The most common cause is pyothorax. We'll see all those radiographs. Okay, let us go to our radiographs. Before that, the radiographic sign. So the radiographic sign, basically the pleural effusion is best evaluated in VD view. Why? We'll see that also. The best evaluated in VD view. So there are some signs. widened interlobar fissures. You can identify these fissures, but if you are finding only fissures, not all of these, then it's not a case of pleural effusion. Okay. Then retraction of long margin. The lungs will be retracted from the thoracic wall. There will be clear space which have a radiolucency. We'll see. You can appreciate that. First of all, let us some theory. Retrosternal opacification. This will be in lateral view. The margin has some name, scalloped margin. Scalloped means curved margin. Curved. It's a shape of ornament or curved. Decreased cardiac cell habitat visualization. This will be in DV view. Why? We'll see just a bit. Obscured diaphragmatic outline. It will find in all views. I told you while dealing with diaphragm, pleural effusion might obscure the thoracic margin of the diaphragm. Next, blunting of costrophenic sulci. This is very rare. You may find, may not find, but if you will find, it is in VD view. There isn't any radiograph which is showing this particular thing, but you may find. Let us jump to our radiographs. Before that, yes, DV and VD. Why the heart is not visible in DV view? You see, when the animal will be placed on, this is DV view, means the animal is in ventral recumbency. In VD view, the animal is in dorsal recumbency. Okay, so when the animal is in ventral recumbency, the fluid will migrate due to gravity. These are fluids. Okay, these are fluids. Here fluid, and the fluid has soft tissue opacity. The heart is also has soft tissue opacity. One thing. Second, if you will measure the depth, in both views, here is the depth and here is the depth, you can see that the fluid depth is more in DB view while the fluid depth is less in VD view. So due to which the overall opacity will be high, and due to fluid which surrounds the heart, they both have the same opacity, heart will not be visible. While in VD, you can see the heart is provided, the contrast has been provided by lungs, so heart will be visible. It is one of the finding or how differentiating between pathognomonic lesion of diagnosing the pleural effusion. Now you understood how the fluid distribution helps or hinders the cardiac cell habitat. Okay, let us see some radiographs so that you can identify. You see, this is VD view, this one is the VD view, this one is the DV view. Okay, let us see some other things, other symptoms. Okay, first symptom is widened interlobar fissures. Can you identify some fissures here? You see there is one fissure here, visible, another one is visible here. Here it is very clear here. Okay, VD view. Retraction of long margin, you can see at the level of fissure, you can see that it is retracted from the margin. There are some small things in DB view, you will see slightly better view, but they are usually visible in VD. Okay, at the level of fissures, you can see there is some retraction. Retrosternal opacification, this is lateral view. Decreased cardiac in DB, you will see that. Okay, so these are the basically signs. Let us go to DB view. I told you because of fluid distribution, here you cannot identify heart. Heart is not visible. Okay, now here actually the long retraction is better visualized in this particular radiograph. Can you see here? This is the long margin. Here is a fissure, long margin here, and the thoracic wall at the level of rib is here, and there is a soft tissue opacity. It means fluid is there, which is causing the long retraction. Okay, this one, retraction of long margin. It is best visualized in VD view, but in this particular radiograph it may not be. It is not that visible. Can you find some fissures? Here is one fissure. I'm sorry. Here is one. Okay. So you can see that all those radiography. We have more radiographs. Let me show you. So you understood the VD and the DV view. Heart is visible in VD view while heart is not visible in DV view. Let us see some. This one is the lateral view. You can see that there will be fluid accumulation on the retrosternal or retrosternal opacification. just above the sternum. You can see that. Can you identify long margin? Here is the lungs. Okay, here is a fissure. Okay, some long is there. And one more thing, you can see that this margins, this is triangular. Okay, it is sharp and triangular. When there will be pleural fibrosis, this particular margin will become like rounding of this margin. Okay, we'll see some radiographs also. Before that, I am telling that this is the normal in pleural effusion with no long pathology. You may see that it is of triangular shape. Can you identify any fissures? One I told you here, one is here. Many times this is confused with heart actually. Okay, so this margin is scalloped. You can see that it is like curved. Okay, so this is scalloped. It means curved, ornamental. Okay, so this is scalloped margin you will find in lateral view. One more thing, when this particular portion is opaque, okay, it is also suspected for diaphragmatic hernia. But here are other signs which you are seeing. Okay, when we will take VD and DB view, in that particular we saw that it is a case of pleural effusion. But if you are taking only one view, we may get confused with diaphragmatic hernia. Okay, so for that you can also take horizontal beam radiography. We will see that also, and you can identify the pleural fluid. So this is basically the lateral view. This is another case. Let us see. This is lateral view. This is VT view. So in the lateral view, you can see that this is heart, margins of heart, but the ventral portion is not visible. You can see here. This is of fluid opacity. Fluid opacity. Okay. Can we identify some fissures? Here is a fissure. Okay, dividing. You can see these lobes actually. And remember the margins. They are triangular. Here is one margin. Here is another margin. They are triangular. It means pleural fibrosis has not been yet happened. So this particular area is radio opaque. This particular region is a retrosternal region. It is one of the clinical signs of pleural effusion. Let us see VD radiograph. In VD you can nicely see some fissures. You see here is one fissure. Here is one fissure, very nicely seen, and you can see that there is long retraction from the thoracic wall here. Here is very nicely visible. You can see these regions are, and remember the diaphragmatic outline. Okay, it is slightly opaque, this particular region. This is kind of fine, but this particular region, you can see the lungs has extended up to this one, but this is basically the slightly opaqueness of diaphragm. But it is, I told you, in order of preference, you see it is slightly less. These are the more prominent signs of pleural effusion: the fissure, the long retraction, and in lateral view the opacification of retrosternal space, and you will find the fissures in lateral also, especially this one. I told you here the two fissures will be there, but they are usually obscured by a heart. Okay, and you can take a DV view to see that whether the heart is visible or not. Okay, so this is pleural effusion. This is another case, but in this particular case there is asymmetric pleural fluid. I told you it is happens when there is the fluid is kind of thick, which cannot be distributed to both the pleural sacs. Most probably it is a pus or pyothorax. Most common cause is pyothorax. You can see this one is the left side, this one is the right side. You can see that right hand side is actually having some pleural effusion. You can see it is very clearly visible. This is basically fluid. Okay, fluid, and the lungs has been collapsed slightly. It has a very smooth margin, but the left side is kind of fine, up to some extent fine. Okay, this is fine, but remember I told you this is smooth margin. When you will go for lateral view, you can see that there is a retrosternal opacification, right? But can you see the margins? Actually it is kind of round. It shows there is pleural fibrosis. Okay, So this is one of the characteristic sign of pleural fibrosity, rounding of the long margin, which should have been distinct and triangular. Okay, distinct and triangular. Okay, so this is asymmetric distribution of fluid. Most commonly it is found in pneumothorax or anything in which the fluid is kind of thick, which hinders its distribution among both pleural sacs. Okay. Now, horizontal beam radiography I told you about some time before. It is particularly very important or very helpful when the pleural fluid is less or scanty or less or minimum, what you can say. What happens actually when the animal will be on lateral occupancy to take radiograph? If you are taking radiograph from here, which is normally vertically you have to take. So when the beams will go, suppose beams will go in this fashion. So what happens, the fluid when it is less, they will be on dependent side. Okay, so for long retraction you need fluid and long interface, so that radiographically you can see fluid as well as lungs. But in this particular case, there is any fluid, so you will not find fluid or long retraction, especially if the fluid volume is very less. So what you can do, you can simply change the direction of the X-ray beam, you make it horizontal. When it will be make horizontal, maybe this particular will not have any pathological sign in radiology, but what about this one? When the fluid will be there, then you will find the fluid lung interface, so that you can identify the fluid as well as the lungs. Okay, let us see some radiograph. So this one is the horizontal radiography in lateral occupancy. You can see that the non-dependent lung is completely fine. Okay, it is attached to thorax, but what about the dependent one? You can see that it is the lung is retracted because of fluid accumulation. Okay, this is retraction of lung retraction. Okay, this is the sign of pleural fluid, especially when the pleural fluid is less. Okay, this is another radiograph. This is horizontal beam radiography. Here the pleural fluid is less, here is heart, you can see the opacification of retrosternal area, but also the diaphragmatic margin is not that visible, especially particularly in this region. It might be confused with whether there is pleural effusion or diaphragmatic hernia. Okay, so what you can do, you will flip the animal in dorsal occupancy and orient the beam horizontally. What happens now? Now the fluid has been accumulated here. Can you see the fluids? This is fluid. This is a fissure here. Now the ventral surface, you can clearly see the heart. Now heart is clearly visible as well as the diaphragm is clearly visible. So it means it is not a case of diaphragmatic hernia. It is a case of pleural effusion. So this way you can differentiate between the diaphragmatic hernia and pleural effusion, especially when the pleural effusion, the pleural fluid volume is less. Okay, so this is horizontal beam radiography to identify pleural effusion. Now, one thing, especially in some breeds like chondrodystrophic breeds, for example, Basset hound. What happens in these breeds? The thoracic wall itself is slightly abnormal. Look at this radiograph. The thoracic wall is kind of more thick. Okay, kind of more thick. It is not a case of pleural effusion. You can say that this might be the wall and the lungs has been retracted, but it is not the case. You can see that lungs has gone up to this. Okay, but the thoracic wall is slightly thick because of the orientation of the ribs. Okay, so the ribs might not be in like in Labrador Retriever or Golden Retriever. The ribs are not that particularly nicely arranged. Okay, You can see the variation of chest cavity, especially contradictory be deep chested animal. For while taking the radiograph of those animals, be careful regarding diagnosis of pleural effusion based on only this. You have to check for other symptoms and signs. This is basically to keep you checked. Okay, just because you found this one does not mean you have to diagnose it. And one more thing, the heart will here is kind of enlarged. In deep chest animal, the heart will be covering much of the space. Okay, lungs will be slightly less, especially on lateral sides in mid mediastinum. So it does not also mean that they have some problems with the heart also. Okay, so you have to very careful, especially in contradystrophic breed and brachycephalic breeds or deep chested animals. Okay. Next, pneumothorax, it means air in the pleural cavity. Radiographic signs, when the air will be present, similar to the pleural effusion, the lungs will be retracted from thoracic wall, but in this particular case, the long margin will have a radio opacity. Long margin. We'll see some radiographs. In pleural effusion, the fluid was of radio opacity, while the long was normal, like black, whatever you found. But in this particular case, the margin of the long, it will be retracted, as well as the margin of long will be radiolucent. We'll see. Focal air collection around the cardiac apex. You know that many times in clinics also you might have found cases of pneumothorax, especially after dog bite. In case of dogs and cats, other dogs may bite and injure the chest cavity, and they will come with pneumothorax. Okay. Appearance of dorsal displacement of heart. You know this one also. We'll see some radiograph. See here. This particular radiograph. See, this is lungs. This is lungs, which has been retracted from the wall. There is a space. This space. Okay. This space. This is space where air is present. But can you notice the long margin? This long margin is kind of radio opaque or radiolucent, you can say exactly. Radiolucent. This is enlarged view. Can you see this radiolucency of long margin? Can you see this radiolucency? Okay. This is the characteristics of pneumothorax. And other thing I told you, collection of air around the heart base, which appears like the heart has been dorsally displaced. Okay, so this is basically the pneumothorax. Let us see. And one more thing, why heart looks displaced? It is actually displaced or what? Okay, so what happens actually when there is pneumothorax and you take a radiograph, the dependent log, which is already atelectic due to pressure of air or due to pneumothorax, it becomes further atelecting and the heart displaced. Okay, heart get displaced. It is not exactly that heart is elevated due to air, only the heart displaced to the dependent side, creating some gap, and this gap, when the X-ray beam will hit, will appear as if the heart has been displaced. Okay. This one is a ventrodorsal view of pneumothorax. Can you identify the lungs here? This is the lungs. This is the lung margin. Here is a fissure actually. This is one lungs. Lungs has been collapsed here. This is a lobe. This lobe is kind of more radio opaque or radiolucent comparative to other part. Might be some other disease might be there. This is lungs. Okay. Can you tell me? I have told you several times what this is. This particular structure, what is this? This is the caudoventral deflection. Caudoventral deflection of mediastinum. Caudoventral. Okay. Now, if you see the cranioventral, you can see this cranioventral. Okay, slightly deflected from the mediastinum. Mediastinum runs here. This is mediastinum. This is mediastinum. Okay, but the deflection slightly runs towards this one is the right side, while the caudoventral deflection runs towards the left hand side. Okay, now coming to the pneumothorax. Okay, so the lungs has been collapsed and this contains the air. Okay, so actually the pneumothorax is best viewed under lateral radiograph. If you took a lateral radiograph, it is more pathognomonic for pneumothorax rather than VD view, but sometimes you have to take multiple views so that you can appreciate those changes or pathological changes. Now, as I told you regarding the pleural effusion, that some hound dogs or some chondrodystrophic dogs or some deep chested animals, they might have some abnormal thoracic cavity for which you may misdiagnose as it is a case of pleural effusion. Similarly, in case of dogs, sometimes they have a small heart or microcardia. Okay, especially when, for example, in the book it has been written that Addison's disease. In this particular disease, the heart becomes small. Okay, microcardia. So in this particular case, due to small nature of heart, it is displaced or it seems displaced. Okay, so it does not mean that the animal has pneumothorax. You have to look for the retraction of lung margin, radiolucent line of the lungs. Okay, all those things you have to look for. Another thing which may misdiagnose that in case of deep chested animal, and if the lung is hyperinflated, okay, deep chested animal with a hyperinflated lung, the heart appears to be elevated. Okay, so what you can do that you can check for the inspiration and expiration radiograph if you are finding this, particularly in deep chested animal. Many of the thoracic lesions in deep chested animal is different from other animal. Okay, they might be normal in deep chested animal, but the exact lesion, if you look for this compared with the normal one, they might be pathology, but for deep chested animal it may not be pathology. Okay, so you have to look for these things, or you have to be careful while interpreting the radiograph as pneumothorax. Another thing, tension pneumothorax, it is basically the same as pneumothorax, only thing is it is tensioned. It means the atmospheric pressure is equal to thoracic pressure, or thoracic pressure is slightly higher than the atmospheric pressure. In that particular case, it is tension pneumothorax. It is a very rare disease in case of animals. But if you are finding the tension pneumothorax, it is a case of 100% emergency. Okay, you have to rush for and you have to do thoracentesis, release the pressure, otherwise the animal will simply die. So what happens, as this is tension pneumothorax, lungs becomes more atelectic. Okay, amorphous opacity of the lung compressed against midline. Because of high pressure, the lungs will be further atelectic. And another phenomenon, tenting of the diaphragm. What is this? We will see. In this particular case, there is one side tension pneumothorax, while this one is completely fine or slightly fine, you can say. See these lungs. This is the lungs. The lungs has a soft tissue, or you can say near to kind of fat opacity. Okay, here is the lungs. This is heart. Okay, this is heart. This is the atelectic lung, and this rest is air. This is air. Notice the diaphragm. Sorry. Notice the diaphragm. Here is the diaphragm. Can you see a bulge here? Bulge here, then the diaphragm continues. Okay, so this bulge is tenting of diaphragm. What happens when there will be tension pneumothorax? The diaphragm will be caudally displaced. While dealing with or taking a lecture regarding the diaphragm, I told you the caudal displacement of the diaphragm, one of the differentiating disease is tension pneumothorax. So what happens when there will be tension pneumothorax? The diaphragm will so forcibly caudally displaced that the costal attachment, here it is attached to a rib, the costal attachment gets pulled. Okay, so while this pulling, it has a bulge. Okay, this is known as tenting of diaphragm. Okay, let us see some other pictures of tenting of diaphragm. This one is the tenting of diaphragm. In that particular case, you can see a bulge. Okay, this is the rib where it is attaches. Okay, you can see this bulge. There is also another slight bulge here. Okay, and here this is another radiograph. You can see here it is the costal attachment. Okay, you can see here it is costal attachment. Okay, this is basically tenting of a diaphragm. It is a feature in case of tension pneumothorax. Along with the lung will be very much atelectic and it will appear as a amorphous opacity. or you can say near to fat obesity. Okay, so this is all about the pleural space. Okay, next class we will go for the radiography pathology of cardiovascular system. So till then, tata, bye bye, take care.